So with that, I would like to invite Professor Vijay Viswanathan, who is the president of DFO International, to give his inaugural, opening speech for our session. Prof. Vijay,
Thank you. Thank you, Professor Harikrishnan Nair. I'll take about 2 minutes before you start with your Western Pacific region. I think the DFoot International is one of the largest organizations which is exclusively for diabetic foot in the world. Our mission is ending avoidable lower limb amputations due to diabetes globally. Ending avoidable lower limb amputations due to diabetes globally. That's our mission statement. Now, the DFoot has a new board since June 26, 2021. And that consists of myself as the president, Abbas from Tanzania as the president-elect, Professor Harikrishnan Nair from Malaysia as the vice president, Dr. Nicholas Papinas from Greece as one of the vice presidents, Dr. Mariam Botros, who's the CEO of Wounds Canada, as one of the vice presidents, and Hermelinda Pedrosa from Brazil, who is one of the vice presidents. So we started, and what we have done in the last 3 months, we have been very active, and we found the first thing which we found was there are many countries which do not have national representatives in DFoot. There are many countries. So what we decided to do in the first 2-3 board meetings we had is to recruit, to include more regional council members. We have a board, and then we have regional council members, and then we have the General Assembly. So we recruited more regional council members from every region. We have 7 regions in the world. And from every region we included more regional council members. And we are in the process of including more national representatives from many other countries in which we do not have members as yet. Okay, so this DFoot Awareness Week, what is the purpose of that? This was started, I gave the idea to the previous board as the president-elect, and we started it last year. And the DFoot Awareness Week, which runs from November 7th to 14th, coinciding with the World Diabetes Day on November 14th, was just to integrate the 7 regions. We found that the 7 regions are working independently. We wanted the 7 regions to work together. We wanted the 7 regions. We have experts in diabetic foot in all the regions. So we wanted to integrate. We wanted to bring all the experts together. So this year, for instance, we started with Africa, and we were astonished to find so much of good work being done in sub-Saharan Africa, which started the first day. The second day, we had the SACA region, which did exceptionally well, South America and Central America. We have wonderful work going on there. Third, we had the North American Caribbean region, NAC. Yesterday, we had the Middle East and North Africa. And I was quite astonished to find people from Lebanon, Beirut, and Syria, Palestine, doing wonderful work in the midst of so many challenges. And we had that program yesterday. And today we have Western Pacific region. So I'd like to first of all thank our board member, Professor Harikrishnan Nair, who's a board member and a regional council member, and also Gulapar, who is also our regional chair member, for organizing one of the best webinars of all the 7 regions. I'm very proud of the fact that you have 200 registrations, which is the highest in all the 7 regions so far, Professor Nair. And it is so pleasing to know that you have such a fantastic support coming from the Western Pacific region. And this is exactly what we want. This will be live recorded and posted on our website, which is called www.d-foot.org, so that anyone across the world can have access to all your talks, and you can listen to what is happening in Africa, or in Central America. So that is the whole purpose of this Defoot Awareness Week. And before I conclude, let me thank once again Professor Hari Krishnan Iyer, Gulapar, and everybody in the Western Pacific region in Defoot for making this possible. And also thank Urgo Medical, who has been a great pillar of strength for us. And even in the Western Pacific region, Urgo Medical has been a great source of strength. They organized this program, for instance. And I would like to thank particularly Nuala Thompson and her team for making this possible. So I wish you all the very best. And Professor Hari Krishnan Iyer, you can please take over.
Thank you very much, Professor Vijay. It's a great feeling that what you call this. We have got, I think, one of the largest registrations. I'll be moderating this session. Professor Gulappa is unable to make it due to family matters and all that. So she has asked to record her apologies. Firstly, what you call this session is being helped. I mean, they're helping us to record, so you should have it on the website. Nuala and team are with us during the whole session. Now, without further ado, we will start because we have got 11 countries. But if you add Professor Vijay, 12 countries basically presenting to you. That is a huge meeting itself. So the first speaker today is actually coming in from Australia. We're following alphabetical order. So Australia is the first one. Professor Stephen Twigg is a good friend of mine, who is actually the head of the Department of Endocrinology and Diabetes High-Risk Food Service in the Royal Prince Alfred Hospital. He's also a Killian Professor of Endocrinology at the Stan Clark Chair in Diabetes in the Sydney Medical School and the Charles Perkins Centre, the University of Sydney. And he will talk to us from the Australian perspective. Steve, you have the floor. Thank you.
Thank you, Professor Hari Krishnan Iyer. Can you hear me, everyone?
Yep, clearly.
And Dr. Vijay Viswanathan is the President of Defoot International and Hari Krishnan Iyer, Vice President. Thank you for the invitation to speak. And I'm also presenting on behalf of two other members from Australia, Dr. Nikki Frescos and Georgina Frank, and Diabetes Feet Australia, which is the national peak body. And this first slide is to indicate as well that Aboriginal and Torres Strait Islanders in Australia have a much higher rate of amputation compared with the general community, at least fourfold, and they're a high priority area for us when it comes to foot management in diabetes. I'm going to focus on learnings from the COVID-19 period, and then just might reduce over here so you can see, and then other collaboratives that we've undertaken 2021, just in the next about 9 minutes. Firstly, COVID-19, the federal government updates practically every day in Australia the statistics, and so this is updated as of yesterday. And we've been blessed in Australia with a lesser number of COVID cases and about 1% of deaths, 1,800 deaths. We're just getting through the third wave, and thankfully the double vaccinations are now protecting us. And whilst the cases have peaked in the age of 20 to 29, the mortality has mainly been occurring in the elderly persons. So pretty similar to many countries. There's been a lot of surveillance occurring, 45 million tests across the last 18 months, and also a lot of contact tracing. So this is helpful data for us to keep a monitor on process. We have had to, from the point of view of our healthcare, make a number of major changes in Australia, and particularly New South Wales and Victoria, the two most popular states. For example, with diabetic foot disease, in the recent Delta outbreak, fewer than 10% really of our patients that we'd see in our high-risk foot services have been seen face-to-face. We've had federal government subsidies, and we've been focusing a lot on telehealth and hybrid face-to-face to keep our patients going. Some of our staff have had to be redeployed to the COVID activities. However, in foot, most of our staff have remained busy in our high-risk foot services and in community care. And then there's been educational initiatives, which I'll touch upon as well. And so there have been major changes in healthcare delivery related to COVID-19 and diabetes foot care. One of the initiatives that was presented at Defoot International last year, and we found it to be useful, is the clinical guide concerning COVID-19 and foot care. and during the COVID-19 pandemic. And we found that we're able to better triage patients to face-to-face, or in some cases telehealth, and also on occasions was the role of home visits in the context really of our high-risk foot services being our main site for managing foot complications. And we have found, particularly in the Delta outbreak, that this has been a very useful paradigm in our most populous states, which had the highest levels of COVID. We don't have a whole lot of outcome data from the COVID period, but local data at our hospitals in New South Wales suggests that the total admission rate was reduced. Maybe people have been less active, 20% or so reduction. But those who are admitted, there was a higher rate of surgery needed, more than half needing surgery. So more severe cases, but less admission. I'm going to now, in the last couple of minutes, just focus on a number of initiatives that we've undertaken during the COVID-19 period. And despite the challenges that we've had. Firstly, very recently, Diabetes Feet Australia launched the Australian Evidence-Based Guideline on Diabetic Foot Disease, and it's adapted from the International Working Group guideline. About 2/3 of the recommendations have been completely adopted, but about 1/3 were adapted for Australian conditions. This was a major undertaking. There are 6 different chapters consistent with the IWGDF. And we also have clinical pathways and a toolbox which is coming online to help all clinicians who manage people with diabetes to have access to evidence-based guidelines for Australian conditions. The second initiative that we've achieved in the last 18 months and more is diabetes high-risk foot service standards and accreditation. And across Australia now, we have approximately 20 centres that are formally accredited and have received appropriate standards recognition by national bodies to help realise the appropriate staff, process outcomes and equipment to realise outcome for our patients and to prevent major amputations in particular. We've also undertaken a national education initiative known as Foot Forward, focusing on clinician education and consumers. And for example, the webinars in the last 18 months, there've been more than 30 of them with more than 3,500 attendees across the webinars. And there's online modules and educational materials for the consumer as well. So I've put the appropriate websites in each case. We know that it's not just knowledge, but even from a physician, Irishman, a long time ago, you've got to look, we've got to teach our patients to look and our physicians to look. The last initiative I'll focus on was only published yesterday, and our President of Diabetes Feet Australia, Byron Perrin, first author. And we believe this is the first time this has occurred worldwide. We established by consulting stakeholders, people with diabetes in particular, and also the industry and professional societies and individuals, what are the 10 most important areas to research related to diabetes foot disease. And the conclusion was the consumers were more interested in prevention and the clinicians more interested in management questions. And then our Australia's first people, high priority. So I commend that to you. It's open access. You might choose to look at that methodology, the Delphi method. So in summary then, I've completed the agenda, focused on challenges that we've had in COVID-19, in some ways less so in absolute terms in other countries, but it has created major challenges to our foot care, and then 4 major initiatives that we've been able to achieve in the last 18 months or so. So we look forward in Australia to not only working more at a national level, but more internationally as we open up again to support DFoot International and right across the region and across the globe. So I'll finish there, and hopefully that's provided you some perspective on what we're trying to realise in Australia and supporting the region too.
Thank you very much, Stephen. A wonderful lecture. I think we move to the next, session. We actually will have a question and answer session at the end of the whole program. So now we move to China, Professor Wu Guandeng, who is actually Professor of Endocrinology and Director of the Department of Endocrinology and Metabolism, Multidisciplinary Diabetic Foot Medical Center in Chongqing University Central Hospital in China. So with that, I would like to invite Professor Deng to deliver your speech. Thank you.
Okay, thank you, Nari. Thank you, Dr. Wiji, and very nice to meet everyone online. And it's my pleasure to be invitation to introduce about the diabetic food management under the COVID-19 pandemic. So now we see this data is a situation of the COVID-19 until today, Luan. And now we also have the more than 3,000 the patients with confirmed the COVID-19 and 20 cases with very severe symptom. So let's have a look about the diabetes prevalence in China. We see that from the 20 years, the very quickly sharp increased for the diabetes increasing. And we also see the COVID-19 with diabetes, endocrinologist, diabetes, the patients with diabetes in any year are more likely to have severe complications from the COVID-19, including the longer hospital stays. And then we see that another study, we see that patients with diabetes and uncontrolled the hypoglycemia was more than 4 times likely to die from the COVID-19. So the patients with diabetes, if they combine with the COVID-19, it's had very bad as a clinical outcome. So we see, except that the diabetes and its complications from the pre-diabetes or diabetes could increase. We see here, concern for the school canal years may increase childhood obesity, and risk of the depression may increase due to the social isolation, and then lack of the care may increase of the complications. Except that we can see longer of the economic downturn has an impact, like we increased the Medicaid benefit or Medicaid insurance increased by more than 4 million. So this is some data. See that the patients with diabetes and with COVID-19 may be very bad the outcome. So at the beginning of the COVID-19, almost 2 years ago, we see a paper published by my mentor on the diabetes care. We see they introduced the 2 cities, Los Angeles and the Manchester. They told us not only in close most of the outpatient clinical face-to-face consultations, but also in the inability to perform most laboratory and imaging investigations. So here, the virtual consultations may be useful for the patient. And in another article, they also tell us, like use telehealth guided home-based like the maggot debridement or another the therapy for the patients. They could not be into the hospital or inpatient or out clinic. So here we also use the flow chart for treatment of the diabetic food published by the IWGDF. The patients with DFU upload the photographs and short video of the DFU. We can use a networking platform, and then based on the IWGDF classification, we distinguish a mild infection or moderate infection or severe infection, and then maybe they could be treated at the home care or outpatient clinic or inpatient. So it also has a Chinese edition for the diabetic food under the COVID-19 that time. Tell people how could we do tell the doctor how could we do for the treatment of the patient with a diabetic foot. So we could see the picture at the beginning of the COVID-19 epidemic. Here, as in the morning, I'm trying to the hospital, almost load the car and the people on the street. Here we just see the ambulance on the street to save the people. So we also use the online service. We have the WeChat group. The patient can upload the picture or the video to tell us how about the diabetic foot now and what should they do next. Also, we also use another one for the community, the doctor. The doctor send us about the medications, and we also send the video to tell us about the food condition. Then we discuss it together, and then what should we do for the patient. Except that some patients also could discuss and talk with the doctor directly. Some of them could also discuss with me. So they can send the picture and the video tell me about the infection of the food, and then maybe you say, hey, I want to be inpatient and to treatment. So we could send also the patients with diabetic foot ulcer, gangrene, and another several conditions, a lot of them. The patients, the amputation, but unhealed. It's a very few ulcers, yeah, and a very severe infection. We can see the amputation, it's not canoia and the infection. So lots of the patients with diabetes, we can direct contact with them or contact with the community doctor. So, and then some patients also with very severe complications, such as like diabetic foot or DKA, and we can see with severe infection on the foot and the skin in the leg and the head. Okay, so and then another patient like this. So after the COVID-19 endemic, the patients has more severe as cases than before. Based on this, we do a research about to how distinguish which patients could be treatment in the outpatient clinic or in hospital. So we use machine learning to distinguish the amputation or mortality of the inpatients with diabetic foot ulcer in the COVID-19 and post-COVID-19 area. So we connect the patients with diabetic foot in the COVID-19 2020, post the lockdown the city. There is 23 patients in hospital to be treated, and we matched them before the COVID-19. We could see that the pre-hospital delay is more 50 days than the patients before of the COVID-19. We also see the patients with the previous DFU, they have more the DFU under the COVID-19. And another one we could see that the more severe infection for the food under the COVID-19 than before. So it's different for the CRP. Here we also can see the hypoglycemia. It's very bad as a mutation. So another one we could see that after the COVID-19 happened, the patients with diabetic foot has more major amputation or minor amputation and the mortality. So we use machine learning. We found it as 6 models in this test setting. We distinguished the different impact factors for the patients to be amputated or to be dead. So there is a WBC, or instead of the infection and instead of the mutation, And then we also could see that the patients with ischemic, maybe they could have a very bad clinical outcome. So I want to say that under the COVID-19 in China, the patients have a very more severe infection and very bad as a clinical outcome, such like some more patients with amputation and mortality than before. Also, in this year, we have the national, the diabetic food symposium of the national in China. We're discussing how to deal with the patients with diabetic foot under the COVID-19. We also have to make a presentation, discuss with each other in a channel way, how to continue to deal with the patients in the next. After all, the COVID-19 seems not to be ended recently. I see maybe 3, 4, or more than some years that. So in my opinion, in the future, maybe the patients came to the hospital, inpatient and outpatient, we should choose a different strategy to help them to avoid to be the amputation or even to death. So that's all. Thank you everyone.
Thank you, Professor Deng.
Thank you.
I think now we move to Dr. M. Munir from Indonesia, who is Dr. M. Munir actually is a senior endocrinologist and country representative for DIFO International for Indonesia. He's based at the Faculty of Medicine, Universitas Indonesia in Jakarta itself. So with that, Dr. Munir, you have the floor.
Yeah, thank you, Hari. And first, I would thank Dr. PJ for inviting me to this meeting. So I will present some data from Indonesia. The data is about the maybe it's already with the diabetic patient and diabetic foot with the maybe problem. This is our objective, the statistic of Indonesian diabetic problem. Who is the stakeholder and challenge for the improving diabetic foot care in Indonesia. This is our data from our national health survey. In 2018, the prevalence of diabetes at that time in the patient, in the people more than 80 years old was 10.9%. This is showing the estimated the number of people diagnosed diabetic in Indonesia is almost 20.6 million. But unfortunately, 70% are undiagnosed. If we compare with the data from IDF estimated in 2020, total diabetes for more than 80 years old in Indonesia is around 10 to 20 million. This is our economic in Indonesia has been the rise over the past years, and Indonesia is slowly establishing itself as one of the world's most powerful economic player in 2040, Indonesia gross domestic product more than 856 billion US dollar. And this is our characteristic diabetic foot in our hospital as referral hospital from 2019 to 2021, as all part of our patient is input in a pandemic COVID-19. As we can see from all the total 150 patients, around 74.2 had a severe infection grade, and more than 50% had peripheral artery disease. And we have looked for the data, 29% our patients should be major amputation at the time, and 21.9% with minor amputation. The inadequate glycemic control among our diabetic patients is always a major problem in Indonesia. Data from one study, Discover study, showed that the Indonesian has the highest level of 1C compared with the other parties in the country. even after initiating the second line of therapy. So this is the bad condition that maybe make increase the risk of diabetic ulcer of diabetic foot amputation in our people. Yeah, how about the doctor? This is the either proportion and general practitioner is 30.4 per 100,000 population. However, in our country, in Indonesia, we have only 11 for 100,000 population. And right now we have 6,000 internists in around of Indonesia. This is going to show the depth of our health worker who have not a balance. And you can see in the slide, we have only endocrinologists. Maybe there is the number, only 140 endocrinologists right now in Indonesia. Yeah. This is the national insurance that cover for all our people. Yeah, from the national data, we have 1.77% diabetic patient who was recorded from the total of 3.9 million diabetic patient. That only 2.15% patient had a glycemic control based on A1C. That we can see the conclude that the management diabetes is not satisfied for our people in diabetes in this time. Yeah, based on IDF data 2020, yeah, in Asia we have a problem the diabetic foot at 5.3%, and however in Indonesia we have the prevalence of diabetic foot more higher with peripheral arterial disease or neuropathy peripheral with around 16% to 32% with the problem neuropathic and peripheral artery disease. This is this is patient with diabetic foot problems should be exercised. We know about that. However, in our data and based our research show that around 50% our patients with diabetes do not have healthy activity, healthy lifestyle. So even it's different background and education and social lifestyle. So almost our people have the same characteristic in lifestyle behavior. Yeah, this is data for our national insurance. Yeah, in Indonesia we have two types of government insurance. First, we call is non-PBI. Non-PBI is mean a payment the insurance by themselves, and the second is PBI. PBI, yeah, there is only for the low income people, and this is covered 100% by government. And in 2021, the total coverage is approximately almost 90% of our population have a cover with insurance. Our national referral system starts from primary care, first year, secondary, with the limited sources of specialist doctor, and the tertiary hospital. In tertiary hospital, we have developed a multidisciplinary approach to face diabetic foot problem. But unfortunately, not all hospitals have the complete specialists at this time. Yeah, several risk factors we have to know about the risk for the diabetic foot problem that come from the patient itself, or maybe from health provider side, and come from the policy maker, from the government, and after the factor is concerned the diabetic foot problem in stakeholder. Moreover, facility in our secondary tertiary hospital are like the doctor specialty in diabetic foot. When the patient comes to the tertiary referral hospital, We have the multiple discipline approach, but we have not yet handled the patient condition maximally. That's the condition make the increase the risk of foot amputation for the people with diabetes. From the rehabilitation care, not all demand for the diabetic foot are covered by government. Insurance such as diabetic shoe or prosthetic. So sometimes a patient after amputation there is no special shoes can prepare for that. The data show several aspects that influence bad outcome our diabetic foot patient, such come with a severe infection, with a history amputation, and high risk of mortality, amputation, and mortality after 1 year is very high. Late detection of a diabetic foot problem or syndrome may cause by system or stakeholder, or maybe from the patient itself. So this is the many risk factor that come increase the bad outcome of our diabetic patient. Yeah. Our in Indonesia we have several organizations to tackle the diabetic problem, include the problem of endocrinology. One of them is Indonesian Society of Endocrinology. Yeah, until now we have approximately 140 endocrinologists spreading to 70 provinces around Indonesia. One of activity our organization is to train the internists and general practitioners about diabetes management, include diabetic foot care. With several training program, we have provide training almost to 2,000 internists and more than 80,000 general practitioners related diabetic management and diabetic foot training program. And the other organization, we have education clinic. Yeah, we have some member like we say the Diabetic Educator Society, that right now we have 4,000 for more than 4,000 healthcare professionals have training for diabetic foot care. And this is our educator. Yeah, it's the team. It's come from a nurse, general practitioner, and nutrition. Yeah, comprehensive management is needed to prevent complications for the foot, a complication that can do with educator. And this is our organization for laymen. Yeah, we have another modality to help us to take care diabetic problem with diabetic foot problem with collaboration with a layman. So many activity to improve the capacity building our patient to self-care of diabetic foot. So we hope the collaboration between the three organizations can make improve diabetic foot care in Indonesia. So this is our last slide. Without the diabetic foot complications, a big problem in our country, and we need the multidiscipline approach to improve our care, and need commitment for all stakeholders to face this problem. Thank you, Hari.
Thank you, Doreen. I think we'll move to the next person. For reason of time, basically, we'll actually push up. So I hope all speakers can keep up to time. Okay, if you look at the Diabetic Foot Awareness Week, we're talking about awareness to diabetic foot care. That's very important. One of the most important dictums in wound management or even in diabetic foot management is basically prevention, prevention, prevention. I'm from Kuala Lumpur Hospital, basically head of the wound care unit here under the Department of Internal Medicine. And the thing is, we are the largest hospital in Southeast Asia with 2,500 over beds. We're also the hybrid hospital now. So during the COVID period, we couldn't close our services because a lot of patients actually had pressure injuries, diabetic foot cases and all that. And we have about 20,000 cases whereby more than 70% are actually diabetic foot problems. So it's one of our main things. The first thing is to show you our DFOO international meeting that what they call is the team was there basically in Thailand, basically a few years before the COVID itself at Taptarin Hospital. And if you look at diabetes, is a global emergency. If you look at what they call this, in Asia itself, basically you can see the numbers are increasing. The Western Pacific region, we actually gone up from 159 million in 2017 to at least 183 million in 2045. But this will be even faster. So I'm just showing you that, it's increasing. Whatever we say, whatever we do, however we try to prevent, it is still increasing. Though there is something that there is a problem with the access to care. So we need to actually try to push up on all these aspects. Now, if you look at this particular slide here, you can see China has some of the largest numbers, not because of percentage per se, it's because they have got bulk of numbers of people. I mean, with 1.4 billion population, basically, a large number, even a few percent will actually have a large number of people actually having diabetes. Now, in Malaysia, basically, you can see from 0.54 million, we went to 2.48 million in 2030. But interestingly, what has happened is, even now in 2021, we have already reached about close to 5 million, which means we have actually superseded what we're supposed to actually reach in the year 2030 itself. And if you look at the study 2015, our population was about 30 million. But the number of diabetics are already 3.3 million in 2015. And if you look at the earlier slide, it's 2.48 million in 2030. So we have superseded the number by 15 years, basically, which means what we call it is not just a simple epidemic, it's a full pandemic. And if you look at limited DFU awareness here is also another big problem among patients, and also the problem in terms of delayed referral to specialist centers. That's why if you look at what we call this, the DDF documents or that they actually looked at delayed referral of patients with diabetic foot ulcers across Europe. So the patterns were actually seen when you look at the primary care and also specialized units. So this is something that we have to actually change. We have to refer them as soon as possible. We can't wait. Now, I will cover some of the projects that we're running in Malaysia in 2021, which is ongoing basically. And these are like the diagnostic kits, the wound kits, and also what we call this, the public awareness and education programs, publications, and also the telemedicine model. If you look at the diagnostic kits, we actually need to have diagnosed these patients early. That means neuropathy, vasculopathy, and all that. So in this particular kits, we actually have got a simple diagnostic foot test kit with a foot examination and a medical referral. So we're actually doing up a study pre and post basically, and looking at 50 centers, that means health clinics and also GPs, and then see whether this will actually help them to detect the cases faster, do a risk stratification, and send it up basically to the hospital. That means the tertiary center in Kuala Lumpur Hospital itself. And one of our targets basically is Kuala Lumpur Hospital will be a referral center, whereby we get it from all these groups. All right. And we need to roll out the training for the GPs on how to use these kits. And these kits will be given free of charge. I would like actually to thank what they call this Ergo, who is a good sponsor of DFOO International, globally also basically, who will actually help us, assist us in these projects. At the same time, we've also got the wound kit program under the Malaysian Society of Wound Care Professionals, whereby we've already given more than 1,200 kits all over what they call this Malaysia, to even NGOs and also to even private facilities, so that patients can actually be trained. Now, one of the things that we have started basically during the COVID pandemic is we have started doing home nursing also. So we have done about 1,800 cases for free for patients who are poor and can't come to hospitals. And bulk of them are actually diabetic foot cases. At the same time, this year, we're doing another 3,350 cases together with the society and the Hasana Foundation for free also. That means our staff who are actually from society are actually paid, but our patients get it for free. Okay, this is actually another charity initiative we're doing. And the wound care kits are also being sent to all these places in the world itself. Now, when you look at adopt a patient, which I'm talking about now basically is, we actually see patients in the central Klang zone, Klang Valley itself, but now we're actually doing it for the whole of Malaysia. So with MSWCP and the Hasana Foundation, more than 3,350 dressings will be done over a period of 1 year. This will cost us about more than $500,000 ringgit basically, where we will actually use it to make sure that these patients who are coming from the B40 group or economically challenged group, where this will help in terms of helping them in terms of managing the wounds. In terms of public awareness and education, we have got the Heal Digest in every year basically. We have also got what we call this the sharing of impact in Malaysia, which I presented during the DFSG meeting in 2021. chaired by one of our vice presidents of DFood, which is Nicholas Papanas, who is actually the chairman of the DFST, the new chairman basically. We're also basically pushing SFSL or Safe Feet, Save Lives on the social media. That means basically on WhatsApp, on WeChat, on LinkedIn, on Facebook, on Twitter and everything. So you need to show them basically in terms of even having ads and all that. This is actually launched in our conferences. Patients also give testimonials about how they actually lost their toes and all that, and how now they are preventing to actually, doing prevention to prevent complications. All right. So most important thing is we also did it in the local language, basically in Bahasa Malaysia or Bahasa Melayu, leading to an increase in earlier referrals, basically. And this is actually the conference that we had during the COVID itself with full SOP. And we actually where we launched the Save Lives, Safe Feet, Save Lives campaign. All right. So you find that what we call this, these are things, the resources that we have, we actually give it. So we actually launched about 1,500 GPs, 450 wound clinics, and Facebook about close to 10,000 followers now. This is actually the launch of it. And you can see basically, it was launched by the chairman of the National Technical Committee on Wound Management from the Ministry of Health. This is just the committee only basically. So we had about more than 200 people during this conference. Now, the other thing is, if you've seen what we call this, a few of them basically, Stephen and Prof. Deng and all that have showed how they use what we call this social media and all that. We also use the telemedicine model. So patients actually basically remotely should be able to actually manage this, and we can actually use the app to actually support the patient, whereby the patients can actually discuss together with their doctors and also the nurses who are giving the thing together with their caregivers. All right. So this telemedicine has to be supported and has to grow very quickly, because one of the things basically is a lot of it is being decentralized, home-based treatment and all that. So you need to be in contact so that at least you can have follow-up with your healthcare professional. If you look at other than mobile phones with camera and all that, where you can actually take the photographs, we also got iPads. We've also got booklets, which are available in the national language, how to do self-care at home, how to describe what you're looking at, and when to know it is an emergency. That means when are you having a foot attack? Also a thing coined by the IWGDF and DFood. Basically, so a foot attack is something that you need to actually detect, look at the danger signs, and come to the hospital as soon as possible. All right. And then if you look at all the different books that we're actually publishing in Malaysia and all that, on looking at diabetic foot as the Asian perspective, and we also got the manuals in Bahasa Melayu, basically the local language, and also in English. And the ASEAN guideline also basically was launched in Malaysia. And with all the other documentations that we're actually doing together with foot care tips, and also looking at the footwear and how to manage ulcers. This is just to show you some of the apps basically that are available in Malaysia, basically, which is your wound doc. Even your ARENS cameras are available here to actually assess the wounds and also measure the wounds and all that. So you've also got the eCare Insight program also. An international consensus document that we have done. Malaysia is also involved with that in identifying and treating foot ulcers in patients with diabetes, saving feet, legs, and lives. At the same time, publications, we did a systematic review looking at the benefits of sucrose octasulfate dressing in the treatment of chronic wounds, especially diabetic foot, because it can be used for diabetic neuroischemic foot. This is another particular study that we published looking at megadebridement therapy and also hydrotherapy, which is leeches, basically to bring down swelling and bring down pain in these patients. We've also used it in organic wound ointments, which we actually used and published this in the Wounds Asia journal. You can see the different, nice beefy red granulation, all that. So diabetic foot is one of our bread and butter, basically. And now we've also moved to using low-level laser therapy. That means photobiomodulation. So this is only one aspect. We also started using the blue light, LED light, basically with EMOLED and all that. So quite a number of things which we're doing in terms of studies per se. So with that, I would just like to thank everyone and say that we're actually having the Asian and Third Global Wound Conference 2021 this year, between the 3rd to 5th of December. This is the first major wound conference in Malaysia physically, basically, and with about more than 2,000 people hybrid, basically. So all the international countries which can't come fly in, Malaysia will actually support in terms of actually coming in for the program itself. Many of our countries are involved in the lectures. Professor Vijay Viswanathan is actually the president of DFood, is also giving an inaugural lecture for this conference. So with that, thank you very much. And I think we will keep questions to the end, and we move to the next lecture, which is from Myanmar, Dr. Tin Yo Han.
I'm just going to share this. I'm just going to share the screen for this.
Yeah. No problem. So Dr. Tin Myo Han is actually from Myanmar. She's actually the family medicine specialist who is a member of the ASEAN Wound Committee and also a member of the Myanmar Wound Care Society. Professor Min Taung is a senior consultant orthopedic surgeon and Professor Emeritus at the University of Myanmar. And he's also the president of the Myanmar Wound Care Society.
Privileged to be here with you to participate in Diabetic Food Awareness Week. I'm going to share my hospital experience upon access to the diabetic food care in Myanmar. Our healthcare system is very organized with both public and private healthcare centers, and the strategic guideline is mainly based on the primary based care. According to my hospital experience, the prevalence of diabetes population is about 11.5% in male population and 9.2% in female population, with the total of nearly 11% of the total populations suffer from diabetes mellitus. It is according to 2019 statistics. We predicted less than 40% of high-risk patients are difficult to access to the hospitals. Less than 25% of the hospital has standard tool for the assessment. Up to now, we have 4 public hospitals: Yangon General Hospital, Naotok Laba General Hospital, Tenganjung Sambia General Hospitals, all are in Yangon, and 1 big hospital in Mandalay have fully equipped assessment tool for the diabetic food clubs.
We can't see anything.
Yeah, just a voice only.
Okay, hold on. Can you see it now?
No.
Hold on.
No.
Right. Hold on. Let me.
I'm going to share my
Can you see
hospital
it now?
experience upon
Yes.
access to the diabetic food care in Myanmar. Our healthcare system is very organized with both public and private healthcare centers, and the strategic guideline is mainly based on the primary based care. According to my hospital experience, the prevalence of diabetes population is about 11.5% in male population and 9.2% in female population, with the total of nearly 11% of the total populations suffer from diabetes mellitus. It is according to 2019 statistics. We predicted less than 40% of high-risk patients are difficult to access to the hospitals. Less than 25% of the hospital has standard tool for the assessment. Up to now, we have 4 public hospitals: Yangon General Hospital, Naotok Laba General Hospital, Tenganjung Sambia General Hospitals, all are in Yangon, and 1 big hospital in Mandalay have fully equipped assessment tool for the diabetic food clubs. In 2021, we have a plan to expand our accessibility to the Naypyidaw Hospital, Magui General Hospital, and Damji General Hospitals. The hospital, Magui General Hospital, and Damji General Hospital, Magui General Hospital, and Damji General Hospitals. In the private base, we do have the 5 private hospitals in Yangon, which have fully equipped assessment for the diabetic food care. During this year's Grand Handa International Hospital, OSC Hospital, Diabetes Center in Victoria Hospitals, and Thailand hospitals and Tamine hospitals. We are facing the double crisis with the COVID-19 pandemic as well as our sprint regulations nationwide. Because of that, our healthcare system delivery is now disturbed with the manual facilities, poor facility, as well as the poor assessment of the patient, especially with the chronic disability like diabetic foot ulcers. Our healthcare resources are now spending in the COVID-19 pandemic, as well as we have the limited resources in the public hospitals, as well as limited facilities for the hospital delivery systems. We continuously growing our public education. So we do have wound care 360-degree program, particularly focused on diabetic foot ulcers, orthopedic surgeon, our endocrinologists, and our community physicians are participating in these programs. And we continue to grow our public awareness program. Up to now, what we have challenges and opportunity. National NCD program have our strict policy and strategy focusing on the diabetes, hypertension, cardiac disease, and cancers. National Diabetes Program has been set up and opened up the community clinic, but only 40% of coverage across the country. We do have specialist societies working together for the diabetic foot ulcer with very good initiative of the inter-societal active collaboration. Initiative of the charity community clinic led by our community physicians in the big cities are successful. System integration for access to the care with the international agency like World Diabetes Foundations. We need to enhance in international collaboration to develop our progress. Our future directions, we need to reset up the healthcare resources and policy driving for the care facilities and coverage once the country situation is begun stabilized. Trainings or trainer program to expand our knowledge and clinical practice among caregivers. We need to promote public awareness and self-management program, especially the home care is very challenging. We need to develop the charity diabetic clinic with the community physicians and voluntary trained nurses, as well as the medical student as well. We need to create the peer control quality assessments for the diabetic foot care, and everywhere we need to provide the best possible standard practice. Finally, we need to be reinforced with the international partners and society like Asia Pacific Diabetes Societies and all the international society as well. This is our short presentation about the hospital-based experience on the access to the diabetic foot care. Thank you very much. And my friend, Dr. Tim Yuan will share the experience about our community practice. Thank you very much.
Dr. Tinmio will present the community part.
Harry, I'm just pulling up her presentation.
First of all, I would like to thank to the Diabetic Foot International giving me an opportunity to share my experience diabetic foot care in Myanmar. Our president, Professor Mieto, has already shared his experience of hospital care. As a primary care practitioner, I would like to share my primary care experience. In Myanmar primary care services, you can see here many primary care providers providing primary care to our community. Among them, private GP clinics are major healthcare provider in city, urban area, and semi-urban area. In rural area, rural health center or the government services and private GP providing primary care to rural community. Charity clinic services are present in our primary care, but limited during the peaceful time of Myanmar. During the peaceful time of Myanmar, diabetes food care services accessibility are still limited in primary care. We have only 4 private primary care clinics providing diabetes food reassessment, wound care, and pediatric care. Yangon, only in Yangon with economic city. The services are still limited in other districts and other areas of the Myanmar. When we hit the COVID-19 epidemic, most of our GP clinic and primary care clinic are shut down because of quarantine policy or our COVID-19 prevention activity. So we open the community fever clinic, charity clinic to provide the need of our community for the primary care. But diabetes food care in that community fever clinics are still limited because of low awareness and limited training to visit healthcare worker for primary diabetes food care services and low awareness by our community. They didn't know to take the primary diabetes food care in that community primary care clinics. In February 2021, we also had another crisis. This is a political crisis. So now we are suffering the crisis for 9 months already. During that time, we primary care practitioners had many difficulties to provide to standard health care to community, including diabetes food care, because of not only the COVID-19, but also political crisis limited to provide the primary care to community. So we had to open the community fever clinic, community-based charity clinic, more and more, and community-based Myanmar Red Cross clinics. Still limitation, diabetes food care in the clinics. During that time, the crisis, we had accessibility and continuity of the community wound care, including diabetes patients, have been still limited in both government services and private primary care services because of the impact of the COVID-19 and the services of the government and private healthcare services. Besides this, we also have financial problem to get the primary care services properly. Because of decreasing trend of the economic growth, you can see compared with the other ASEAN country, we also have the decreasing trend of the economic growth. Therefore, to limit the healthcare services by the community, especially vulnerable groups. So we primary care practitioners are noted that we need to provide more basic wound care training to our primary care provider, including GP, medical student, nurses, volunteer, and family member, via the available resources to narrow down the need of the community wound care services and to increase the accessibility to basic wound care services. We also had to provide the affordable wound care dressing material to community to get the easily accessible or the accessible by our patient for their wound care training at home. So finally, we noted the empowering and supporting on our diabetes patient to take care of their own during the crisis in the Myanmar. So this is our patient who are suffering the diabetes foot. So the patient need to do the surgical wound treatment at hospital, but the patient had to do the wound treatment at home because of the limited access during the third week of the COVID-19, and the services or the hospital services during the crisis. And then we had to train our patient and family member to do wound dressing at home. Luckily, the patient get a better outcome of the wound care after 4 months of the dressing. This is we also using the private services to coaching our student, our patient, and then the family member to do the wound dressing at home by themselves. So this is a real situation or the accessibility to the basic wound care services, including the diabetic wound care in the Myanmar during the difficult time of the Myanmar. Thank you so much for your kind attention. This is a sharing of the experience of the Myanmar primary wound care situation during the difficult time. Thank you so much.
Thank you very much, Dr. Tim Myo Han and also Prof. Min Tong. Now we move to the next lecture, which is from New Zealand, basically. I would like to present the speaker, Dr. Jeffrey Carnett, who is actually a doctor of podiatric medicine. He actually got his degree from the US. He's worked basically even in Hawaii and Hong Kong, and he's currently now in Auckland, New Zealand, as the team leader of diabetes podiatry for the Waitemata District Health Board in that area. So with that, Jeffrey, you have the spot. Thank you.
Okay, thank you very much. I really appreciate this opportunity to share a little bit about our experience, and I'll talk mainly about delivery of high-risk foot care, diabetic foot care in New Zealand. I'm based in Auckland, but I'll talk in general because we are a small country, about 5 million people. Many of you live in cities that have far more than that as far as population goes. And our situation, of course, kind of, as we say, on the bottom of the world. However, we live in a very multi-ethnic country with different effects of delivery and access of diabetic foot care through the communities. And while we have, we're in a country about the size of Great Britain with a population of 5 million people, people are quite spread out. So it's a bit difficult sometimes to deliver high-risk foot care. So essentially that's the population. Last I checked, by ethnicity, we have about 74% are European. And then indigenous Maori, indigenous people of New Zealand, Maori, about 15%. Asian, which is just general, all Asians grouped together, about 12%. And then non-Maori Pacific Islanders, about 7%. And about 1% is Middle Eastern, Latin Americans, Africans. Are you all able to see this presentation?
No.
You can't see it, okay.
I can see it.
Yeah, okay. Let's try again.
We can't see your slides.
That's what I want you to see.
Yep.
That's the good part. Don't need to see me. That's the good part. Okay. Current situation with high-risk foot, type 2 diabetes affects about 5% of the population. Leg amputations in a most recent study affected 26.6 people out of 100,000. By comparison, a study compared it to Canada, which is slightly less, 58% in New Zealand of the major foot and leg amputations were related to diabetes. there's been a 40% increase in major leg amputations in the past 5 years. As I alluded to, delivery of high-risk foot services, diabetic foot services, varies to a certain degree. There's been a 40% as an increase past 5 years. However, there's a 56% increase in leg amputations in the Maori population, 59% increase in Pacifica population. Maori health services are lacking in high-risk foot services in general. While people of all different ethnic groups live in all the cities, certain areas of the country have a larger percentage of population that are Maori. And those centers tend not to have provision for high-risk foot or difficulty in access. So here in Auckland, we have in the Waitemata District Health Board, we have a Maori health unit that employs a podiatrist under our department. And we are podiatry under endocrinology in our health board. However, in other parts of the country, there are outreach clinics to different populations, which sometimes can have limited access to specialist services such as vascular surgery, orthopedics, and such. So that's our challenge, I guess, is to see if we can improve these statistics based on essentially just having access to services. So the healthcare system, essentially there's 20 district health boards. Primary care is funded by the government. All the high-risk foot and diabetic foot care involving what we call secondary care, which is involving wounds and other acute conditions such as Charcot, are taken care of in the hospital. GPs surgeries will do education and screenings. There's a provision for podiatry, general podiatry services 3 times a year via the GP referral. However, if there's, that's done by community podiatrists. So some of those are in centers that are funded by the district health boards, and some of those are private podiatry practitioners who have contracts for providing non-acute diabetic foot care. So those, not every practitioner can have that contract. The contract's based on having ability to do screening and having, Dopplers and being able to have showing a certain level of understanding and screening and when to refer. When there is a wound, it gets referred to us in the secondary, in the hospitals. And it's a multidisciplinary approach in all the hospitals. The members of the multidisciplinary team in the hospital may vary based on the geography and the services that are there. There is a future goal of the Health New Zealand. So there's, over the next few years, they'll be disbanding the district health board system and put all the healthcare, so all the hospitals and all the community care under one agency, one government agency. And Maori Health will have its own authority. So they'll be pulled out from Health New Zealand, and the Maori Health Authority will be in charge of managing health provisions for Maori and Pacifica populations. This is in recognition to the disparities in access. So at this point, a lot of work is being done to decide, who's going to be formulating the Maori Health model for the diabetic foot, and how can it be improved upon. So in general, this is how we manage. We break down the cases into the low risk up to that higher risk. And just this is a flow chart showing that the private podiatrists will do general care and recognition, and then it would be increased up to referral if there's a wound, going all the way up into the hospital. And then specialty services, we refer, we work quite closely with orthopedics and vascular surgery. And of course, being under endocrinology, the podiatrist works with them initially. Podiatry services involve clinic-based debridements, minor operations under in the appropriate procedure room setting. And when we have the patients healed, we move them to a remission clinic where we have podiatrists that are doing the general care and monitoring and re-emphasizing diabetic foot education. And then once it's determined that they're really not in a situation where they're likely to re-ulcerate, we refer them back out to the community, thus opening up opportunities for more acute conditions to come in. In a nutshell, that's how we do it. So some of the things we're working on and some of the things that we need to improve upon, as I mentioned, remission services. So this is under a government grant where we have brought into the hospital private practitioners, for private podiatry community practitioners who've come in for 6 months to 2 years working in the high-risk foot clinic with us and with the physicians and surgeons to perfect their skills in assessment and management of the diabetic foot. The idea is when they go back out to into the community, then we know that they'll have armamentarium of being able, all the tools necessary to assess the foot and to refer into the secondary services as needed and appropriately. There's also provision for diabetic footwear. So patients with diabetes, with neuropathy and deformity, history of ulceration, can get one pair of extra depth diabetic shoes through the hospital. We have scholarships for Maori and Pacifica students to go study podiatry. We also have a high-risk foot multidisciplinary team sessions monthly with endocrinologists, the diabetes nurse, podiatrists, vascular surgeons, dietitians, and orthotists. The challenges, of course, in the high-risk foot training and developing for podiatrists as well. There's one podiatry training program in New Zealand, a bachelor's degree program, and not all the students will have placements in the high-risk foot. So there is that issue when people graduate, if they haven't had much experience in the high-risk foot and they're in the community, they may have a hard time getting that experience. So in our case, we have set up a high-risk foot clinic 1 day a week at the university. So more students have an opportunity to work in the high-risk foot clinic there. And I man that clinic. We also have 5th year medical students that do placements in the high-risk foot clinic, which is very valuable because as they become physicians, they'll have a better idea of what services are available in the hospital setting for the diabetic foot. And quite often it's quite interesting to see the basic knowledge, I guess, of the high-risk foot and assessment that they get in their didactic training in medical school. So we're able to kind of show them examples of what can go wrong and what can be prevented. Now, one important thing is the high-risk services are not standardized across the country. Different hospitals have different resources and they have different skills in their specialists. Some hospitals have foot and ankle orthopedic surgeons and some don't. Some have a very aggressive vascular team, as we do, where even prophylactic vascular surgery is done, preventative early intervention, I guess is the way to say it, is done, allowing for elective orthopedic surgery. For example, doing revascularization and then doing an elective bunionectomy in order to reduce pressure areas. However, in some centers, it's essentially peripheral vascular work is really on the last resort for people who've have acute ischemia rather than earlier stages of the disease. Again, the goal of Health New Zealand is to get rid of some of these differences. the healthcare system being divided as it is into different district health boards. And that's based on geographical location, your place of residence, which hospital you would need to go to and which doctors you could go to. And there are cases where somebody can live within a couple of kilometers and they could get at one hospital, they would be able to get a certain service. In the other hospital, they're not able to get that service. So the idea of centralizing the healthcare system is to remedy some of those differences. And then again, the Maori Health Authority would be to hopefully increase the access and get rid of some of the, some would even call it institutionalized discrimination that has developed and occurs in the healthcare system. So that's all I have for this afternoon, and I appreciate the opportunity.
Thanks, Jeffrey.
Thank you.
Move to the next lecture from Associate Professor Dr. Aziz Nader from Singapore. He's actually a senior consultant and he was in the National University Hospital. He's also the secretary of the Asia Pacific Association and a member of T-Food for Singapore. Prof. Aziz, you have the floor.
I think, can you put the video on, Nuala?
Yes, I'm doing that right now, Prof.
Thank you.
Make
I
sure.
would like to take this opportunity to share with you. Can't see the video, Nuala, only sound. Diabetic foot.
Sorry.
And the many more challenges.
No
video that we will face ahead. Must screen share.
Yeah, I'm trying. Give me a minute.
And that is very important. That's better. But where we fail and a complication has developed, we fail.
I'll start it at the beginning.
I would like to take this opportunity to share with you the journey that we have gone on diabetic foot and the many more challenges that we will face ahead. We adopted a two-pronged strategy. The first strategy is prevention of complication, and that is very important. But where we fail and a complication has developed, we will form a team with a clinical pathway to manage it, and best managed by a diabetic foot team clinical coordinator. The key to the management of diabetic foot wounds is prevention. Prevention and more prevention. Now, where have we been from now? We formed the diabetic foot team in 2004, this partnership between Dr. Cheong, an endocrinologist, and myself, an orthopedic. And we gave birth to the first Asia Pacific Conference on Diabetic Limb Problems. We also hosted the 5th conference, and we went on to shoulder the 10th conference as well. And that was a long journey. Singapore has a second highest proportion of diabetics after the USA in developed countries. So it was quite a comfort when Minister of Health declared in Parliament war on diabetes and setting up a new task force on 5 fronts: prevention, screening, control, understanding diabetes, and do your part. And so we have come up with this algorithm that we have to do education, 90%, food screening, 10%, and central to all this to be successful, we need government involvement. And they have committed forcefully on 5 fronts. Who do we educate? The patients and caregivers, 80%. Don't forget healthcare professionals, 20%. We have started on a public awareness program and education using these education pamphlets in our hospitals since 2014. Care of diabetes, care of the feet, choice of footwear. We also did a fair share of educating of healthcare professionals so that they can provide better quality care and running workshops, nursing workshops, screening workshops. And we have actually provided material for these education, 3 textbooks: Diabetic Foot Problems, the diabetic foot, and surgery for diabetic foot. Strategy 2. What has the team achieved? Our study shows that it reduced average length of stay. It reduced the major amputation rate from 31% to 11%. It also reduced the complication rate. So we were fairly successful. But there are problems ahead. We need to streamline a new clinical pathway. The hospital became online and the manual clinical pathway became obsolete since 2015. So we need a new online pathway, a CDOC, and that needs time, and we don't have the budget to, and are waiting for a new EPIC system which has not arrived. So that delayed things. We also need a hospital registry for diabetic foot. That will come easy once the CDOC pathway is on board to evaluate clinical outcomes and for future research. So the launch date has been delayed by no budget, my own back surgeries, and my retirement that followed suit. Sharing with you a new team, the challenges of the new team, the Sengkang General Hospital Diabetic Foot Team. They form a team orthopedic podiatry chaired by Francis Wong, an orthopod. And he followed the NUH system of diabetic foot and pathway with aggressive early management to provide a one-stop shop. And this is Francis' team. And there you are, his system. And it's not long before he quickly brought on board 2 plastic surgeons to get better results and flap coverage, better limb salvage. And they began to save more difficult problems like this one, half the foot. And this one, even septic arthritis, irrigation, inflow, NPWTI, they can save such. The challenges they face, the progress, of course, is rapid. They benefit from the NUH experience. They reduce the amputation rate by 60%. But version 3, they realize need to come, and that's the interventional radiology for angioplasty, so that they can get better below-knee amputation rates. Now, the CDOC pathway and the hospital registry that I talk about, they are taking on board simultaneously, and they hope that it will be completed after about 1 year by December 2022. And this is the new Sengkang team. The challenges of COVID give us quite a bit of headache all over. The DM team round stop in NUH unaffected. We, since 2018, adopted the sit-down case presentation style because of patient confidentiality. The Sengkang team adopted the face-to-face rounds, and they are slightly affected. Now, elsewhere, outpatient clinics reduce, elective surgery stop, emergency admissions, and emergency surgery only. So where are we now with regards to the war on diabetes? Needless to say, it has been halted. The COVID-19 factor is the biggest factor. The new election factor is another factor, 2020, because we've got a new Minister of Health. The National Committee for Public Awareness has been dismantled. So the machinery has been arrested. So we decided that waiting for a new machinery and waiting for COVID to go away will take some time. We decided to adopt a new sectoral approach, a step-by-step approach, perhaps a modest adopt the northeastern sector approach first, and that is tripartite in Sengkang, tripartite partnership between the hospital, the polyclinic, and the club. We will hold a public awareness club walk by the club, a public awareness talk in the hospital, and provide free food screening as well, and use whatever material we have already garnered. Simultaneously, we'll run out professional awareness program in Sengkang, a public professional awareness symposium in the hospital for general practitioners mainly, and nurses and podiatrists. We have a new book that will be launched, Understanding Diabetic Foot, a guide for general practitioners for that purpose. And we will be providing lectures to College of General Practitioners. This is being planned. The next step, if that is successful, we will roll out similar program to the Western sector, for example, Bukit Batok, or to the Southern sector, Bukit Merah, or to the Eastern sector, Tampines. There are other challenges ahead. The road ahead is long and difficult. We need to engage more HMDP international experts by MOH for guidance. People like Keith Harding, who came to us, and Jerry Raymond, 2016. We need to introduce P&O service for diabetic foot to provide better shoe, both preventive and therapeutic. We need to engage the latest technology, for example, 3D printing for custom-made insoles for better offloading, better assessment time, such as PAT assessment of perfusion of foot or phlegm. So in conclusion, 18 years after we started, a long road ahead, the team approach Kidney Pathway was successful, reduced the below knee amputation rate 11%, but to get better than that, we need better revascularization techniques. Microangioplasty is not enough. Window period only 6 months at the most. Angiosomal revascularization, perhaps still a dream. Open vessel bypass maybe needs to come back. We don't know. The key strategy for diabetic foot program is still prevention. We need to perform more public awareness program for our patients, more food screening for all newly diagnosed diabetics, more professional awareness to train our healthcare professionals to better provide quality care for our patients. I would like to end a few words on the Association of Diabetic Limb Problems, which I started. This is an association of healthcare professionals in the region, formed in Singapore 2004. We now have 13 member countries, Australia to Vietnam. And we are very active. The next 3 conferences are 2022, India, 2023, Melbourne, and 2024, Singapore. Because this is our 20th anniversary, we hope to bring it back to Singapore, the country where it's all started. We would like you to join us and be a member of this association. And well, doctors, nurses, healthcare professionals, podiatrists, all share equal rank in our association. Just fill in this form and send it to me. I'll process them. And if everything is all right, I will pass it on to Gillian, our treasurer in Australia. And she will also contact you how to complete the payment. And it's about 70 Australian dollars annually. The life membership is $140 Australian. Do join us, and it's a worthy cause to help improve the quality of life of our patients with diabetic problems. Thank you very much, ladies and gentlemen.
Okay, Harry, are you?
Yeah, thank you very much, Prof. Aziz. I think we move to the next topic by Professor Yu Yao Hong, who's actually the Senior Consultant Endocrinologist in the Division of Endocrinology and Metabolism, Department of Internal Medicine, Changgung Memorial Hospital in Taiwan. So, Prof. Yu, you have the floor.
Thank you, Harry. I would like to talk about the diabetic foot disease in Taiwan in the current status. So, according to the National Health Insurance Research Database, we can see that the figures show the status of the diabetic foot cases every year, and you can see the increasing of the years as diabetic foot cases. So when we look at the total population is 23 million, and the diabetic foot population, diabetic population is 1.6 million, and still increasing. And so along with the increasing number of total diabetic population, the number of patients with diabetic foot complication increased to so far is 30,000 per year. And it's about the 1.9% of total diabetic population have the annual event of diabetic foot complications.
So let's see the treatment and the status of the amputations. So we can see the red line. The red line show the endovascular therapy. So so far, it's about 6.6% patients receive endovascular therapies, and the bypass therapy is not increased. Actually, it's a little bit slow. But when we see the amputation rate, you can see the black line. The black line show the major amputation rate is dramatic decrease from 3.9% to about 1.9% in year 2017. And the minor amputation is also has a decrease of the trends. So in 2017, it's about 3.3%. And though we still have the COVID effect, we have the activities between University Hospital Diabetic Footwear Combined Conference. So let me show the event of the this April, and we talk about trend and studies and how to care, and we also invite our distinguished friends from Japan during the e-meeting. And this slide shows our recent published report. We come from the limb-threatened foot infection with more than 500 cases, and we after adjust precisely about panel. After adjust all the clinical factors. So the model A, B, C, D show different adjustment of the different clinical factors. And we can see that the gram-negative bacteria, when they exist, it affected the outcome of the treatment significantly. So the lower panel show that which bacteria in which component. So you can see that the minor amputation, the most significant effect bacteria is Proteus, E. coli. And for major amputation, Klebsiella, E. coli, and Morganella has their role. And for death, it's Acinetobacter. And the COVID pandemic in Taiwan is relatively stable, but we still have an outbreak in this May. So you can see this photo between May and September is this outbreak peak over here. And this slide demonstrates the diabetic care in Chang'an Memorial Hospital, in my hospital. And this is the major diabetic food center in Taiwan. We care, you please see the black line. Black line is cases per year. So we care almost for about 400 cases a year. But in year 2020, because of the COVID and the cases decreases to 373. And for the amputation rate, which is in about 9, in year 2019, it's about 5% of the patient under treatment has major amputation. But for the COVID years, this increased to 9.4%. So it means that the patient delayed to come in, and the foot is more deteriorated, and the treatment outcome is bad during the COVID years. So this slide, I would like to share our limited experience of the technology assist care model for patients with limb-threatened foot ulcers. So when we look at our data, our patient received multidisciplinary team treatment for peripheral circulation, wound debridement, and the infection at hospital. However, after their discharge, the wound healing rate is still not good enough, partly because of the difficulty in wound care at home. So as well as the COVID come, so we try to use the home hospital community home cares with the telehealth model. So the team care and the patient at home, we use the app for the sugar control diet as well as the food status. So from April this year, a total of 21 patients discharged from our diabetic foot center. For those, sorry, the healing ulcer patients is 30 patients has healing ulcers, and the median healing rate, healing time is 94.4 days. Those patients received about the mean of 6.8 tailored instruction during the course for the wound, how to care their wound. And one patient experienced not chest pain, is wound ischemia of the wound, and referral for the cardiovascular OPD. And one patient has a hypoglycemia management through the tailor visit. For those anterior ulcers, they also received the mean of 7 times of tailor instruction for the wound care. Okay, and 2 patients referred to plastic OPD because of the deterioration of their wound. Let me show the, I think, a special case. This gentleman has, you see the minor amputation of his foot, and he was intended to have a flat construction for by plastic surgeons, but you see, due to the COVID outbreak, he cannot come. So we had to use the telehealth assist treatment all the way. So you can see that it surprised me that the wound is closures after 5 more months. So this is our limited experience. So thank you very much for your kind attention.
Thank you very much, Prof. Wong. I think next we move to Thailand, which is Associate Prof. Tipapon Tarawanich, who is actually the endocrinologist from Thammasat University Hospital. She is also the Secretary General of the DM Food Club of Thailand. Prof. Tipapon, you have the floor. Thank you.
Thank you very much. สวัสดีค่ะ Greetings from Thailand, and thank you very much for your introduction. Let me make it to be full screen. So, in Thailand, we have the population of 70 million people, and around 5 million people has diabetes. Yes, and the prevalence of diabetes has been increasing in the past 10 years. Recently, published data revealed 1 out of 10 adults have diabetes, which are more than the goal setting in 2009. The Ministry of Public Health implemented the strategic plan for diabetes prevention, early diabetes detection, chronic complication screening, and foot ulcer management. The budget has been allocated in the involved segments. The universal healthcare in Thailand covers most of the population. It is provided through three main sources of medical reimbursement, which are civil service welfare system for civil servants and their family, social security for private employees, universal coverage scheme for all Thais, and other schemes for reimbursement such as private sector and veteran scheme. For universal coverage, the patient do not have to pay if the intervention or medication used are in the national list of the essential drug. The government hospitals has been categorized into primary care, secondary care, and tertiary care hospital. As you can see, the number of primary care is about 10,000 hospital or unit. So how can we be sure that the hospital perform well in the diabetes care? For quality improvement, many professional associations such as Diabetes Association of Thailand, Thai Endocrine Society, Pediatric Endocrine Society, Thai Diabetic Association, Diabetes Educator Association, and also Nursing and Midwifery Council of Thailand cooperate with the Healthcare Accreditation Institute, or we call it HA, to establish self-assessment guidelines. And then this hospital can improve the quality of care. After that, each hospital perform their self-evaluation and classify themselves into diabetes clinic, comprehensive diabetes clinic, and diabetes center. After that, HA will arrange a survey of the hospital that voluntary would like to receive disease-specific certificate for diabetes care. So this is the voluntary process. Thailand had many versions of diabetic food guidelines. The new version is expected to be released next year. For medical personnel training and patient education, Thailand had many professional organizations that focus on diabetes, such as Diabetic Food Club, Diabetes Association of Thailand, and Thai Association of Diabetes Educators. They also cooperate with other organizations to continuously support education, and they arrange many conference and meeting for the training personnel. So to access to diabetic food screening, the patient can access to diabetic food screening and education at least yearly at primary through tertiary care hospital. If pre-ulcerative lesion is detected, primary care unit can manage by themselves or refer. This is the result of diabetic food screening. As you can see, it's increased, the green line, it increased from 44% to 70% of diabetes patients, nearly double in the past 8 years. What happened after the DM food screening? The medical personnel will categorize into low, moderate, or high risk of ulcer, and they have guidelines as shown. Moderate to high risk category could undergo more frequent comprehensive food exam, and proper footwear would be provided in the high risk population. Footwear and foot orthoses that are reimbursed for high risk patients are such as total contact insole, PTP AFO, toe filler, shoes, foot orthoses, walking boot cast, and pro walker. So these are all reimbursed. If there are difficult cases, so medical personnel can use the telemedicine or network system to help. So this picture pinned the Diabetic Foot Clinic network aligned with Silirat Hospital. It is an example of the network that consult each other through telemedicine. Not only network of the medical professional, the patients can also have peer support through Diabetic Foot Club. Currently, we have at least 167 Diabetic Foot Club across 5 regions in the country. For the access to diabetic foot ulcer treatment, we have basic wound care, offloading, and revascularization.
We have 1 million in the bank lab, and then another million in the money market, which doesn't even higher interest yung sinasabi that.
No, hindi dyan.
And all of it were in reimbursement scheme.
Pero yung
Our
pera
tertiary-
anytime, pwede mong i-withdraw.
Our tertiary care hospital and some of secondary care hospital can manage diabetic foot care in different specialties. And telemedicine has been implemented in some area for consultation and treatment. As a result, the amputation rates were decreasing and met the primary goal to be less than 0.44% in 2020. In conclusion, patients can access diabetic foot screening at primary through tertiary care hospitals. Primary prevention of diabetes and its complications are supported by national policy. There are referral system, network, and guidelines providing for medical personnel. Diabetic clubs promote self-care, behavior by peer. Telemedicine is implemented in some area, resulted more access to care. Thailand has reimbursement system that cover almost all people in the country, and quality improvement is enhanced by hospital accreditation system. For area of improvement, education of diabetic foot care and human resource are lacking in some area, and the medical professional organization will arrange more education in this. In some places, equipment such as monofilament or ABR are not available, and advanced wound care products are not reimbursed in the reimbursed list. So, and we do not have good patient registry to retrieve related data of DM foot, and more research and innovation are needed. So, ขอบคุณค่ะ and thank you very much.
Thank you, Prof. Tiapon. Now we move to the Philippines. Basically, Dr. Enrico De Jesus and Dr. Luina Thompson will present to us their perspective. Enrico, you have the floor. Thank you.
Some slide seen on the screen. So ready in the screen.
Yeah.
Yes, we can.
Thank you very much, Professor Hari. This is the timeline of COVID-19 pandemic in the Philippines, when the first case of the disease from the foreigner was confirmed. The fourth and fifth cases of COVID were both Filipino citizens, making them the first and second cases of local transmission in the country confirmed on March 6. On March 16, the government imposed an enhanced community quarantine, a total lockdown restricting the movement of the population except for necessity, work, and health circumstances in response to the COVID-19. Additional restrictions mandated the temporary closure of non-essential shops and businesses. In the healthcare system, COVID-19 became the game changer in terms of priority of patients management. Non-COVID patients were put to sideline, and wound care, unfortunately, was considered as a non-emergency. Although COVID-19 is mild in most cases, the elderly and those with underlying comorbid condition can have severe complications. In most cases, these are the wound care patients. The three most common underlying conditions that are at greater risk of COVID-19 are diabetes mellitus, hypertension, and vascular disease. What are the challenges? The government have urged and regulate that all non-essential care be treated remotely from the hospital to prepare for the expected influx of infected patients. As a result, services and surgeries that are deemed non-essential are being shut down immediately. Hospital outpatient wound care departments have been placed in the non-essential group. Non-healing wounds left untreated and unmanaged results in significant medical issues, including infection, sepsis, the need for limb amputation, or even death. What else? Diabetic wound care has changed dramatically. Prior to the pandemic, we provided the regimented care to our patients with ulcers. Then, the COVID-19 pandemic turned healthcare upside down, shattering the wound care supply chain in the process. There were under-treatment to the diabetic foot patient as they cannot access proper medical care due to lockdown. Fear and inaccessible healthcare management. During the COVID-19 pandemic, typical wound care paradigm have been severely affected. There was a shift of care from healing at all costs with a face-to-face consultation to prevention of hospitalization and utilization of services. During the pre-pandemic, the goal for most patients with wounds was healing on any cost. If a procedure or hospitalization could be performed to improve the likelihood or speed of healing, it was done. However, since the pandemic is shifting the site of wound care and reducing access to best practices, the goals has changed. During the pandemic, the major goal of wound care will be managed of the wound in order to prevent serious wound complication and hospitalization. Avoiding procedures and hospitalization reduces the risk of COVID-19 exposures to wound patients and preserves needed supplies for the health system. Understandably, with access to some advanced diagnostic and procedure, there will be a notable effect on the expected outcome. For example, the prevention and diagnosis and treatment of infection of wounds must remain paramount, but there will be a higher tolerance for limb ischemia and longer wound healing time. What are the goals of wound care? For patients with non-critical wounds, like stable ulceration and dry scar, the general aim for wound management during pandemic is primarily to ensure a level of wound care that prevents deterioration while limiting unnecessary in-person visits to minimize potential exposure to the virus for both patients and healthcare providers. The wound care community must accept that the goal is not necessarily to complete ulcer healing or wound closure, though this may occur. Other challenges like undertreatment were noticed as patients foregoing wound care in fear of catching the virus. Some patients tried to take care of their wounds themselves with varying degrees of success, while others neglect their wounds completely. These are the different factors of undertreatment. Patients may not always get the appropriate dressing deliveries, or they did not always apply the dressing correctly. Patients have often had to evaluate the condition of their wound with limited mobility, impairments of vision, and without proper knowledge of what to look for, and the surgical debridement could not take place. The standard of care developed for wound care clinics was changed. It is important to increase the clinical efficiency of the system to minimize transmission of the virus to healthcare workers and to the patients. The staggered patient scheduling, restriction of visitors, free visit phone calls for triaging, and the use of algorithm help us stratify those patients at highest risk of hospitalization, emergency visits, and non-healing. In addition, a more liberal adoption of telemedicine became the important source of our treatment option. These are some of our experience. These are the pictures of our diabetic foot we encountered during this pandemic. If you cannot see your patient regularly, it is most important that your treatment does no harm. Use simple non-adherent dressing that patients on their carriers can use without the need for specialized equipment or experienced clinicians. We ensure the patients of the carriers can continue to monitor the patient's foot ulcer and for infection or other signs of deterioration. In addition, we make sure that the patient knows who to contact and where to go if their ulcer becomes infected or deteriorated. During the management of diabetic foot ulcers, it is mandatory to observe effective protection protocol. Medical care, healthcare workers, and patient safety is an essential objective to avoid transmission of the COVID. A multidisciplinary team is a must, and elective surgery should momentarily be postponed. In patients who require limited surgery, operations can be delayed, as such delay do not alter the condition or its management. For patients who require emergency surgery, like debridement, local decompression, the normal surgical procedure can be followed. When COVID-19 has been excluded, or the surgical team will wear a level 4 level of personal protective equipment if the surgery cannot be delayed. In case of diabetic foot or any wound per se, one must determine the severity of wound. If there is no infection or mild infection in the wound and there is no fever, local wound care is sufficient and a weekly online consultation can be planned. If there is a moderate wound infection and there is no fever, debridement at outpatient wound center and local wound care are sufficient. And if there are severe signs of infection, hospitalization is needed. Now, urgent surgical intervention is not required. Treatment for diabetic foot infections such as intravenous antibiotics, fluid replacement, a multidisciplinary team approach with immediate surgical intervention such as debridement and single-stage radical surgery with preferable local and regional anesthesia block. This is the level of PPE use during the face-to-face consultation. The level 4 in COVID-19 wards are being used. In the operating room, it requires the most protection for personnel. This level of PPE protection consists of overalls, surgical cap, N95 mask, scrub suit, goggles, face shields, double gloves, and dedicated shoes and shoe covers. For the level 3, it is used for the triage and areas where patients under investigation are admitted. PPE protection consists of cap and goggles or face shield, N95 masks, gloves, gowns, and coverall. In our experience during the pandemic, there are 3 wound centers that were monitored. Majority of the patients underwent debridement and minor amputations in skin graft. About 1% had major amputation, which happened during the time of total lockdown. These are the samples of the pictures. In one of the government hospitals where diabetic foot is being catered, this is the census of diabetic cases where those diabetic foot cases are being handled from January to October in 2022. A total of 71 cases of diabetic foot infection with equal distribution of sexes with the mean age of 59 years old was seen. Majority of the patients were in Wagner 4 with localized gangrene, and many patients presented with Wagner 3 and 5. Surgical procedures, 43% underwent major amputations, the below knee amputation and the above knee amputation, while 22% had minor amputation and the rest had debridement. Now, what are the activities of the Philippine Wound Care Society during the pandemic? We attended and participated in webinar on wound care in time of pandemic, challenges and opportunities in the present day wound management last September 23, 2020. Webinar on pressure injury in times of COVID, October 2020. Webinar on venous leg ulcer, comprehensive assessment and management with Professor Harry as a speaker, one of the speaker on oxygen therapy as treatment of venous ulcer last November 2020. Another webinar on complex chronic wound management last January 2021. How newer antibiotics can help was done in April 2021. And our Philippine Wound Care Society, in cooperation with Asia Pacific Association for Diabetic Limb, in cooperation with POFAS, a global care for diabetic foot, was conducted. This was a very successful webinar done this year. And lastly, last July 25, Peripheral Artery Disease Awareness Day celebration, a seminar or webinar was conducted, and participants reached up to 6,900 with high engagement and interaction and with positive feedback. That's all, and thank you very much.
I think with that, we go to the last presentation coming from Vietnam. Dr. Mai Trong Tri is actually an endocrinologist and diabetologist in Ho Chi Minh City in Vietnam. He's also a member of DFO itself. Dr. Mai, you have the floor. Thank you.
Okay, can you see my slide?
We can.
Yeah.
Thank you. Good evening, everybody. It's my honor to be here to share with you about how Vietnam adapts the food national research in the setting of COVID-19 crisis. Learning is an exciting process and important too. However, it's difficult to adapt on up knowledge and experience in clinical setting. Like Philippines and other countries, Vietnam has experienced COVID-19 crisis in June of this year. And not only did patients suffer from COVID-19 disease, but they also suffer from get a lot of trouble with health service problem or economic problem during the lockdown period. And in the first phase, during the first phase of COVID-19 crisis, we seem so we seem so focused on COVID-19 victims, and we forgot other patients who also need healthcare service too, and this may cause the problem delay in treatment, increasing rate of amputation or mortalities like Philippine situation. I would like to share with you two cases as my patient. The first one is the male patient who suffer from long-standing diabetes along with serious comorbidities. He had wound at the left toe, but because he afraid of getting disease, COVID-19 disease. So he decided to stay at home and treat himself. He only contacted me after his wound become severe infection. And right after hospitalization at local hospital, he had amputation, but he passed away later. And this is his time at his hometown, a very sad story. And the second one is a female patient. She also had diabetic foot ulcer right above the ankle of the foot, up her foot. However, she contacted doctor immediately, and she was classified as able to be treated as outpatient. The most important is she keep contact to the doctor, and she keep send the picture for me to follow up her wound and treat the wound appropriately. And eventually, his wound become healed. Her wounds become healed, even though it took longer than usual. So during the lacking of resources in COVID-19 crisis, we need new appropriate approach, and telemedicine is one of the most important thing. This fact pathway from default international is one of the most important thing. It's an inevitable and natural trend in the setting of lacking resources and obstacle of moving. Telehealth is one of the most hot topic in lockdown academy. However, when we apply to Vietnam setting, we have to adjust to suit the Vietnam setting. We do not have professional software to measure the wound size or measure wound temperature, and it's also very difficult for patients and their family members to use these professional software. We use Yellow instead. This is one of the most popular communication platform in Vietnam, and most of Vietnamese get familiar with this platform, and we use it to communicate with our patient and encourage them to send us pictures to follow the wound. We also use this platform to consult COVID-19 patient at home too. And we both know that telemedicine or teleconsultation is not easy because we need the initiative from both doctor and patient. So that's why we need a guideline to help the doctor and the patient communicate effectively. Thanks to the expert from Default International and a gold sponsor, a booklet of guidelines for teleconsultation for diabetic foot care had been developed from around March this year. This project took more than 6 months and 5 official meetings and experts from 8 territories. From around September 2021, we had this booklet. We had this booklet translated into Vietnamese. And right after we have Vietnamese version of this booklet, I share immediately this booklet to our college through a virtual conference, and it gets a lot of attention from my college. And after the conference, a lot of college contact me to get this booklet. International Working Group on the Diabetic Foot Guidelines is also very important research, and we also translate it into Vietnamese, and we also introduce it in a virtual conference. Dr. Trần Quang Nam introduced this guideline to our college, We also published this guideline on Vietnam Association of Diabetes and Endocrinology official website. They help our college access this important resource easily. During COVID-19 pandemic, we recognize that vaccine play a very important role. However, we also recognize that vaccination is much more important. The research from the Food International is very valuable, and it's a rewarding to for learning from them. However, it's much more meaningful to apply for our patient effectively, rapidly, and appropriately. That's why that's the most important thing that I learned from this COVID-19 crisis. Thank you for your listening.
Thank you very much, Dr. Mai. I think one of the things that I saw in your slide was the transparent mask. You can see the lady with the lipstick and all that. I haven't seen that actually, so something interesting. Anyway, I think we have got a short period of time basically to look at an open discussion. So I think one of the first things is we just make, what do you call this? We just look at the group. I think, does anyone have an answer to why COVID was delayed in so many Western Pacific countries? Was it heat, humidity, outdoor lifestyle, late introduction of Delta variant? It was the same in Cambodia when they were there. No community outbreaks until March 2021. Okay, interesting, directly about COVID. Has anyone wants to try?
I have a question of Associate Professor Thipabron from Thailand. Can I have a question?
Yes.
Thank you. I'm very
Yep. Hi, Unir.
I'm very interested about how you organize to screen diabetic foot at the primary clinic. However, screening diabetic foot is not easy. So how you train or how you organize to train for general doctor to screen diabetic foot, and easy there any difficult to train in that process? Thank you.
Yes, because it has been, we have diabetes guideline, and this guideline is provided through the countries, so the people can do as the guideline said, and it's also the KPI. I mean the index of work performance in each hospital. So the government hospital has to push themselves to have more and more of diabetes screening in the hospital. For the primary care, we have many levels of primary care. They don't have so many patients in their hands, so it can do easily. But for the quality, that's the 70% are the screening rate, but we have to look also the correct, whether it's correct or not. So the HA hospital accreditation is one of the system to see whether it's correct or proper or not. So that's the system.
Any other questions? If there are none,
Thank you, Associate Thipabron.
I think there's no other questions. Stephen, can you explain, or can you just explain, I mean, in terms of Fiji, and you do a lot of work with Fiji and Solomon Islands and all that. How is the prevention of diabetic foot going on there basically at the moment?
Yes, thanks, Dr. Hari. I think we need more information. The situation in Fiji, I think, over time has sometimes been well organised and sometimes less organised. And I think our friends in the Pacific need more support. at the beginning of this week, Diabetes Feed Australia had its national conference, and we are trying to get more organised with different Australian organisations and linking in with IDF, with DFOOT WPR, but also IDF WPR, Dr. Hurry. So I think we've still got some work to do. Yep.
Thank you. Any other questions from the floor? I think if you haven't, I think thank you very much. I think we move to the launch of the DM Food Telemedicine booklets by the Western Pacific Region Ergo Working Group. Noella, you have the floor. Thank you.
Right, thank you very much, Harry. I'm just opening, here we go. I'll go to full screen. Can everybody see my slides?
Yes.
Yep.
Yes.
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 Okay,
Yes.
so why are we launching this at this forum, I think, is probably the preface. So Ergo Medical have been working with a lot of the regional colleagues, and you've seen both Harry and Dr. Mai present the booklets, but it was a collective effort of a lot of experts and hardworking clinicians who recognised the challenge of COVID very early on and the impact it was having on seeing patients. And what we've seen across all the countries, not only in the region, but in the other regions, is a lot of the treatment was transferred, whether you talk about supply chain for dressings or you just talk about the basic care, was transferred out of the wound clinics or the emergency departments or the podiatry clinics into the home, where either patients or carers for patients were looking at doing the care. So this is the project team involved in this. I was very honoured to be part of the team, but I was basically the gopher for everyone else, and we got a lot of work done in a short period of time. So one of the things we recognised is, what did we need for healthcare professionals? Was it the same? So when we looked at designing the project, was it the same for patients as healthcare professionals? There are similarities, but we realised we needed different language in certain aspects of the booklet, and we needed to make it very simple to read and infographic in its appearance. And at the end of the day, it was then localised into all the countries' languages to support them. There's no point developing booklets in English, to my mind, because, you know, a lot of people do speak English, doesn't mean they read English. So we looked beyond that to not only supporting COVID, and I think we have to recognise in a lot of countries in Asia Pacific, some patients struggle to get to the healthcare clinics or to get to a hospital, and that's due to their finances or their family challenges or geography. So, but people have phones. But just because you own a phone doesn't mean that you know how to use it in this scenario, was the feeling of the project group. So we developed two booklets. One was for they were both for telemedicine. One was for a healthcare professional, and then we looked at the topics that were essential, and this was the consensus. And these still continue to be localised at a country level. For example, in Australia, it will be localised to the Australian standards. But we really followed a diagnosis treatment dialogue. This model was really inherent to make sure that it covered all aspects of care. And then we looked at facts about it, because remember, we're aiming a lot of these at healthcare professionals, nurses, GPs, very tertiary setting aimed. We wanted to identify what the risks. We still feel that there's not a great understanding of the risks, or Nuala's ability to run a keyboard. We also looked at taking from DFOOT International the risk assessment and the DFU referral pathway. Remember, this is the booklet for healthcare professionals. A key point in this is not every patient is suitable for remote care. So we also give a guide to doctors. You can't just tell everyone, though COVID did tell everyone, that they must be cared for at home. You've got to understand, do they have the cognitive skills, the understanding, or do they have a carer close to them to support this? Basic guidelines on how to treat a wound and care for a wound, fundamental aspects around hygiene and hand washing, how to look after yourself. And this is the conversation that a lot of clinics, nurses would have with the patients or the carers in the clinic. The strong feeling for the group was wounds can get bad really quickly if you're a diabetic with a diabetic foot ulcer. So they need to understand both the positive and the negative signs so they could act quickly and respond if a foot attack was imminent. And another key request from the group was to include information on if you do heal a foot ulcer, give some clear information and guidelines on how to prevent reoccurrence. Then we had a booklet for patients, and it's a slightly different story. We were focused more here on the foot attack, recognising signs and symptoms for local wound infection, and aspects about how to conduct a telemedicine. If you talk to a patient about a wound and you're asking them to describe exudate or the size or the odour, it means different things to different people. So we tried to standardise a lot of that as much as possible. And we also recognised there was very early cultural differences for the different countries. And Dr. Mai was brilliant at this in identifying what was needed. Prof. Deng in China has also done some adaptation. And for Australia, the booklets will also be adapted very slightly differently, but enough to make them relevant in the individual markets. So this was a simple thing, giving them some facts, and we also looked at basics of how often to train the treatment. And through the booklets, we've incorporated the Save Feet, Save Lives for the individual countries where these booklets are aimed at, so there's more awareness and information if required. Again, facts about diabetes. We find people, despite the fact that they have diabetes, have some blackout zones, still don't understand fully, or their family don't understand the impact. Taking care of my foot at home, you can see this is more patient-centric. How to look after my diabetic foot, my wound, positive and negative signs again. We're encouraging good habits for healing, and I can hear myself, I'm rushing just to get through in a timely manner. And again, most importantly, if you heal a wound, we want to keep it healed. We want to prevent reoccurrence. So this is part of the overall education that the working group felt was essential. The biggest thing is, how do you have this teleconsult? I've heard all of you today to talk about moving care from, in the tertiary setting. And how do you have these consults? And if you don't have the super duper laser or app, you're just dealing with the patients and you're trying to have a conversation with them in normal language and describe a wound so that you both understand the same thing. This is where this booklet's aimed at describing not only how to look after the wound, but describe the wound to your doctor. So these are minor aspects, but we've been really clear to include them, which is all well and good. They're available in both digital and paper copies. And I was thinking last night I might make an ebook. I'm not sure if that's still relevant. We'll see what works in different platforms for things like Zello and different platforms in different countries. But who are they for? So the healthcare professionals, we really identified GPs, podiatrists, endocrinologists, wound clinics, all those places are essential. And for the patient booklets, it's pretty much anyone, but we feel they need to be promoted through the associations so that if patients are going to the association website for information, this is a tool, and it's a very simple tool. One of the things that I think Harry and Dr. Mai and other people who are using the booklets are already talking about is whether it's Save Feet, Save Lives or it's these telemedicine booklets, our goal at Ergo Medical is not to make them inaccessible, which is why we've translated into these 8 languages. And, on request, based on, what else is needed, we would look at that. But we're starting with this to see how it's rolled out. So traditional Chinese and simplified Chinese, that covers China and Hong Kong. The Thai language, we have it in English, obviously. Malay Bahasa, Vietnamese, and Tamil and Hindi. That doesn't mean we'll stop at this, but we want to make them established with these 8 languages to see if the need continues beyond where we are today, we would look at changing and updating. So on behalf of Ergo and the wonderful team in the region who work so hard on these booklets, I just want to say thank you, Dr. Vijay, Prof. Azir, and Prof. Deng, Dr. Mai, Sina, Panika, Dr. Singh from India, a fabulous job and created a very simple tool which I think has great value and is available on request. Thank you.
Thank you, Nuala. I think we've just gone through what they call this, the whole marathon with all the speakers from 11 countries. And I just want to reiterate what the board basically of DFood is actually planning for this time, because the new board is very interested in expanding our numbers. And the thing is, you can see in this particular session, we've actually increased and we put in Myanmar also. So Tim Johan and also Min Tong is coming. And then the next groups and all that, basically Laos also will be added on. And I think Stephen will help us to get people from Fiji, Vanuatu, and also from Solomon Islands. And these are other countries which are also in our region. So at least we can become bigger, we can support each other. Now, one of the main things, if you can see, the limitation to access of care and what we have all presented, and there's a lot of recommendations in this time. I think a lot of us now basically have gone to telemedicine, telehealth, looking at information technology. And I think one of the things that, before I leave you, I would like to mention is to show how much of passion is in this group, or even in the new board with the regional chairs and also with all the country representatives. It's something from what Mother Teresa has actually mentioned. It's not about how much you do, but how much love you put into what you do that counts. And I think today we have seen in our wonderful marathon session, 11 countries, including India, basically 12 countries have come together. This is the longest, I think, marathon the whole week I've seen in the whole 7 regions. And one of the most important things is we can do a lot of things. And the other quote before I finish is, I can do things you cannot, you can do things I cannot. Together we can do great things. So that is how our whole multidisciplinary team comes in, and we can see we have got the endocrine group, we've got the orthopedics, we have got podiatry. So all of us need to work together for our patients. So with that, I would like to thank all of you all, thank Vijay, thank the board, thank basically the regional chairs, as well as all the speakers today for spending 2.5 hours of your time. I mean, the thing is time is very, very important. And it's good that we only delayed by about 5 minutes. So with that, basically, it's a great thing to bring the whole region with more than 11 countries in, and time management was superb. So with that, thank you very much. And this is going to be a yearly affair, so you can start preparing for next year also. Thank you.